We'll start Dr.
Yes.
Shireen, Professor of Internal Medicine at Shams University, and she's the moderator of this session about chronic hepatitis B.
Thank you, Dr. Fatma. Good afternoon, ladies and gentlemen, professors and colleagues. I would like to welcome you to the third session today. It will be about hepatitis B virus. First of all, I would like to welcome the chairpersons, Professor Dr. Fatma Murad, Al-Azhar University, Professor Dr. Qadri Al-Said, he will be with us online, Dr. Raghda Marzapan, Cairo University, Dr. Terry Magdi, and Dr. Wala Hashim, Ain Shams University, and Professor Dr. Yahya Shazli, Ain Shams University. We will start the session with the first lecture. It will be presented by Professor Dr. Patrick Kennedy from UK, and it will discuss all the hepatitis B virus updates regarding the diagnostic and therapeutic modalities nowadays. Thank you for waiting, Professor Dr. Patrick, and please you can start sharing your slides.
Thank you very much. Firstly, I would like to say it's a real pleasure to join the meeting again this year. I'm just very sorry that I'm not in Cairo with you all and that we're doing this remotely, but we will make do with what we have. I'm looking forward to having an interesting discussion, and I'll start today by giving you very much a clinical update on hepatitis B around functional cure, because I think that's what you're all most interested in and interested in seeing where the developments are in the field. So briefly, this is an outline of my talk. I will talk about what cure is in chronic hepatitis B. This is something we've discussed many times previously when I've traveled to Cairo as well with previous talks. Then we'll look at existing antiviral therapy and achieving functional cure. Here we will look at the nukes that you regularly use in the clinic, be that entecavir, tenofovir, and of course TAF, which is now available in Egypt. Then we will look at stopping existing antiviral therapy and how that may lead to functional cure. There's been a lot of data on this in recent years and remains a lot of debate around this strategy. And finally, we will talk about new agents to enhance viral suppression and functional cure. So this is really the big area of my talk, because this is the area where the most research is. This is where the most clinical trials of novel therapies are in development. This is a slide you will be familiar with. It's a slide that I used and have previously talked about, where we look at the different disease phases in chronic hepatitis B. And this is important because we're still talking about these classical phases of chronic hepatitis B, be that e antigen positive chronic infection or formerly immune tolerant, e antigen positive chronic hepatitis, e antigen negative chronic infection or immune control, and then e antigen negative chronic hepatitis. Of the four disease phases, of course, we only offer treatment in two at the moment. That's the e antigen positive chronic hepatitis and the e antigen negative chronic hepatitis shown here. What I want to talk today about is what the cure goals are and what we're really trying to achieve. So on the left of this slide, as you look at it, we can achieve viral suppression with the nukes that we talk about, and we can do this effectively if people are adherent to therapy, be that entecavir, tenofovir, and TAF, all very potent drugs and very successful at achieving functional cure, at achieving viral suppression rather. Then we look at partial cure. What is this? This is considered off-therapy sustained virological response, but we don't think this is good enough because we know that in many cases we'll get rebound, we'll get viral relapse, and you'll go on to get hepatitis again, and then you'll need to restart treatment. So we think partial cure, although it is a potential step up in terms of progress, in terms of treating cure, it's really not adequate. So then what we're focusing more on is functional cure. And functional cure, of course, is surface antigen loss with or without seroconversion. And at present, with currently available therapies, only 10% of patients on long-term nukes over a long time will actually achieve functional cure. Below this, I refer to complete cure and sterilizing cure, but I think these really are not within reach, certainly not at present, and I would not say for a considerable period of time, because the technologies are not there to really eliminate cccDNA, and in terms of sterilizing cure, eliminate all viral particles, which will of course include integrated virus. But I do believe that functional cure is an achievable goal. And I refer to that as the immediate goal because this is where all treatments and all clinical trials are working towards at present. You'll all be very familiar with these data from the Global Hepatitis Report in 2017. And to any of us who look after hepatitis B, I think we find this quite a sobering slide. 8% of patients with chronic hepatitis B globally get treated, so that's less than 1 in 10. We know that there are 257 million with chronic hepatitis B worldwide. We know that only about less than 10% we believe are diagnosed, and we know that, as I said, in numerical terms, less than 8% on treatment, which equates to about 1.7%. And don't forget with chronic hepatitis B, when you're managing chronic hepatitis B, that really we are trying to prevent disease progression and HCC. And HCC globally, the lead cause of HCC globally is indeed chronic hepatitis B, with accounting for somewhere between 700 and 800,000 deaths per year. I mean, these are really quite startling numbers and really highlights to us the necessity of improving how we manage hepatitis B and how we better offer treatment. I talked about functional cure with nuke therapy, again, referring to entecavir, tenofovir. There's lots of data around entecavir and tenofovir because we've been using them for so long. Less data around TAF, and we'll see that emerge over the coming years as we develop more data and real world data. But we do know that in those patients who are treated with entecavir, in terms of achieving surface antigen loss, it's only about 2.5% at 7 years of follow-up. In those treated with tenofovir, it's probably around 10% in those with E antigen positive disease. And I know that in Cairo or in Egypt, you don't have a great deal of E antigen positive disease. So only 1.3% in those with E antigen negative disease at 7 years follow-up. So we can see really how these drugs are not successful in terms of offering functional cure. And this is what highlights the need for us to have newer or better therapies to manage chronic hepatitis B. I'm not going to focus on pegylated interferon as I've showed you there. One of the next things is to look in more detail at these various stop strategies or treatment interruption strategies, because you will be interested in this because I know you have many patients in your clinics on nukes and you want to know that after 3 years, 4 years, 5 years, 6 years, is it possible to stop nuke and achieve surface antigen loss? Well, there's been many studies, and I'm just going to touch on some very recent ones which were presented within the last year. This is a study from ASOLD of the STOP study. And essentially, the message that I see every time in all of these studies is that, yes, you can stop nuke therapy in some people. Yes, you will achieve surface antigen loss in some people, but this is a very unpredictable approach. And in fact, we know now from the emerging data that nuke discontinuation in Asian patients just doesn't seem to work, because what you get is you will not get the functional cure that we want to achieve. And even though you may get some surface antigen decrease over time in these patients, many of these patients end up being retreated. So this is a really important point. And especially now the data is emerging, which is showing us that it seems almost impossible for us to achieve functional cure in certain patient groups, and specifically in the Asian group that I referred to here. This is the RETRACT study. So this is a stop nuke therapy globally, which involves patients from both North America, Europe, and Asia, E antigen negative patients at nuke discontinuation, some patients with E antigen positive disease, but I will discuss them differently. And then we're looking also at the rates of cumulative retreatment in these groups of patients. So essentially, what we're seeing here is actually what I referred to in the previous slide, is that even in these big cohort studies, looking at different ethnicities and different genotypes, we are seeing again and again that this ability to have a treatment interruption or treatment discontinuation to achieve functional cure is something that we can only really observe in Asian patients. We know that the overall rate of surface antigen loss after treatment cessation really is quite poor. Although we know that there's a low risk of decompensation, liver decompensation because of flares, and mortality is quite low. The problem again and again is that this is an unpredictable approach and that it works very poorly in Asian patients. There may be some success in Caucasian patients where it can be 6 times higher in terms of surface antigen loss, but the end of the day, we're still unable to really identify those patients well in terms of what patients where treatment could be stopped to achieve functional cure. So this is what's been at our disposal, but unfortunately, it doesn't really move the field forward for us. I'll now move on to talk about the new therapies that we are trialing or various stages of clinical trials, largely from phase 1, phase 2, and moving into phase 3. And what I want to start by is focusing on these various targets. So you will see here, number 1, this is inhibition of viral entry via NTCP, so the HBV receptor. Number 2 is interference in messenger RNA to inhibit protein synthesis. Number 3 is inhibition of capsid formation. So these are the capsid assembly modifiers. Then interference with core antigen-mediated cccDNA replenishment. And then finally, the inhibition of release of neutralizing antibodies shown down here. So if we move on to the first of these agents, this is Mercledex, which has been around for some time now, and this inhibits viral entry. And just recently, in fact, Gilead have acquired this. You'll see more trials emerging and more data emerging from Gilead having bought Mercledex and its use. However, Mercledex, being an entry inhibitor, can be mimicked by things like ezetimibe, can also be mimicked by things like cyclosporin analogs. And essentially what it's doing is it's blocking entry of the virus into the uninfected hepatocyte. And we want to know, what is this doing to surface antigen with and without pegylated interference? So rather disappointingly, what you'll see here is that when you look at Mercledex cohort alone or the interferon cohort alone, we're actually seeing more surface antigen reduction in the interferon cohort, and interferon combined with Mercledex in this hepatitis B population. We're seeing no superiority when Mercledex is combined with pegylated interferon over pegylated interferon alone. So again, this is maybe bringing us back to the reality that these new drugs and the application and utility of these new drugs may not straight away offer us the necessary wins that we want in terms of these therapies coming into the field. However, what is interesting and what is emerging, and the data is certainly growing, is that Mercledex has a place and offers us more in the treatment of HBV/HDV co-infection. So essentially, we're seeing definite benefit by the use of this entry inhibitor in Delta infection. And if you look at the data here, you're seeing the treatment period, the follow-up period, and changes in surface antigen. But to just cut to some of the data for you, you will see doses of Mercledex here. And oddly, at the lower dose, they reported the greatest effect of Mercledex when combined with pegylated interferon. And in fact, what you're seeing in the antigen-negative patients at week 72, 40% of patients experienced a surface antigen response, and 27% of those lost surface antigen and 20% seroconverted. So this is very promising data, but we still need some clarification on this. The reason why the lower dose of Mercledex seems more successful, the reason why Mercledex in combination with pegylated interferon is more effective in Delta infection, and these are something that we'll see in the coming years with emerging studies. I'll now move on to the targets, and these probably are the most exciting targets in the field at the moment, and this is why I'm going to focus quite a bit on the siRNAs and the antisense oligonucleotides. So just from the outset, it's worth pointing out to you that many of the companies you see here, Roche, Johnson & Johnson, Vir, Arbutus, etc., Johnson & Johnson again, and GSK, they almost all have these antiviral agents targeting the with siRNA targets or antisense oligonucleotide. But what you want to know is, where are these actually targeting within the hepatitis B? And here I'm showing you 2 agents which are targeting the S open reading frame, and then many more targeting the X open reading frame. So we'll want to know, as we look at these data, is there a difference when you target these different parts of the virus? Is there a difference in outcomes? Is there a difference in targeting integrated DNA from non-integrated DNA? And the studies that we will look at, and the studies over the coming years, will certainly help us with this. So starting with the Johnson & Johnson siRNA, these are drugs, as you can see here, are administered every 4 weeks or once monthly. And these are data from this trial, which they're administered with 3 injections, and then you have this long follow-up. And I'll draw your attention to the bottom of the slide, first of all, showing you that beyond looking at surface antigen, all of these studies now look in some detail at HBV RNA, HBe antigen, and HBe correlated antigen. But of course, functional cure is about trying to achieve surface antigen loss. And that's why we focus more on the changes in surface antigen I'm showing you here. And all of those in yellow are showing you the very positive responses to the siRNA with quite significant reductions in surface antigen after these just 3 doses, remember. And you can see at the bottom of the x-axis as we move out that many of these surface antigen responses are in fact maintained. So this is a very good sign from very early data. Now moving on to some of the other siRNAs which are out there. What I want to just show you here, this is a very simple study showing you again in terms of just 2 injections, the significant surface antigen change that you get from baseline with quite rapid reductions of surface antigen. Here you'll see at week 4, week 8, week 12, and week 16. Remember, the treatment is stopped here at this 4-week point. So these siRNAs seem to have a very long activity, a long effect, even after dosing with them, with this surface antigen tail reduction going on for some time. And this is an indication providing us maybe with some insight as to how we might use these drugs, the frequency we might use them, and the possibility of getting away with maybe with injection at 2 months, 3 months. Future data will confirm this for us. Moving on to another siRNA, again, I'm just showing you this is the Arbutus drug 729. And again, the striking point that you will all note on these data is that you will see the dramatic reductions in surface antigen that you're seeing in some of these patients. The red on this graphic here is showing you the mean individual, and the gray are the actual individual reductions. So you will see even across the board here out to week 12, the quite marked reduction that we're seeing in surface antigen with these siRNA technologies. And this is certainly something where I think the field, there's a lot of excitement in the field that this will offer as something significant in terms of reducing surface antigen and moving towards functional cure. And then of course, if this is the Arbutus data, this is about repeating the dosing of the 729 product, 60 milligrams every 4 weeks, results in continuous surface antigen declines beyond 12 weeks. So what you're seeing, repeated dosing, 4-week intervals, and you're seeing the surface antigen continue to reduce out to 5 months. I mean, to me, this is really quite striking. And I think it is really underlining to us, looking at the mean reduction in surface antigen here versus the individual reductions again, that the benefit or potential benefit of these technologies in terms of achieving surface antigen reduction. We've talked about siRNAs up until now. This is an antisense oligonucleotide, and I wanted to just focus on this also. This is the Johnson & Johnson product. This is the GSK product, the GSK 3228836. And what this is doing, very similar effect as early as day 29 with significant reductions in surface antigen, again, both treatment naive and on treatment patients. And you will see here, if you compare it to placebo in the on-nuke therapy, the marked reductions that we're reporting in surface antigen, and basically in patients on nuke therapy, a greater than 3 log reduction by day 29. This is really quite impressive. In treatment naive patients, a greater than 3 log reduction day 29, but only in 3 out of 12 patients. Again, the question comes back to, will there be certain cohorts that we want to use these drugs more commonly in, i.e. should we be using these drugs only in patients established on nuke therapy? And these are things that the future trials will really determine for us and provide greater insight as we move forward as to how best to employ these in later phase trials. Now moving on to inhibition of capsid formation, reduction in cccDNA replenishment. I think most of you from attending all the meetings in recent years will be most familiar with the capsid inhibitors because the data has been around for the longest. But if you look at a capsid inhibitor, to me, this is probably where the data is maybe most disappointing. We know that the capsid inhibitor can interfere with pregenomic RNA encapsulation and DNA replication, so they're affecting this cycle here, but they have another effect And this is the replenishment or recycling of the cccDNA. Now, naturally, you would think that if you're blocking encapsulation here, it would take time to have the downstream effect in terms of capsid disassembly and cccDNA formation. So maybe the reductions in surface antigen that we want to see in terms of functional cure would take later to come. But the issue, I guess, that we all have with capsid inhibitors, and I'm just showing you here that when you look at capsid inhibitor dosage, you combine it with various drugs, for example, with pegylated interferon here in the red, what you're seeing is rapid and quite marked reduction in HBV DNA and similar rapid and marked reduction in HBV RNA. And you can see this within 4 weeks in some of these drugs. The difficulty is, what's interesting on this slide is that there's no surface antigen shown you, and that is because capsid inhibitors do not really reduce surface antigen as much as we would like to. This is another later stage capsid inhibitor, and what you're looking at here is basically the use of the capsid inhibitor in combination with NUC, and then in an e antigen positive cohorts, treatment naive and virologically suppressed. The question here is, in e antigen positive cohorts with higher levels of viremia, do we see greater levels, similar levels of viral reduction and reduction in pregenomic RNA and HBV DNA? The short answer to this is that we do, that these capsid inhibitors are equally as good at getting HBV DNA in treatment naive patients to the lower limit of quantitation, and similarly for pregenomic RNA. There's not an issue here with reduction of the HBV DNA or the reduction of the intrahepatic viral constituents. The apparent stumbling block seems to be its capability of reducing surface antigen and therefore achieving functional cure. The obvious question would be, will it be more effective when capsids are delivered for much longer and we see a much more downstream effect of the drug? And then finally, I just want to briefly talk to you again or show you again in these e antigen positive cohorts. Again, we're looking at how we can reduce HBV DNA in these next generation capsid inhibitors. Within 2 weeks, we can see these really marked reductions in HBV DNA, HBV pregenomic RNA, really highlighting the antiviral efficacy and the potency of the antiviral efficacy with capsid inhibitors, which is a really important message to take home. Finally, I'm going to talk about the inhibition of release of surface antigen, and you'll all be quite familiar with this. You'll be familiar with the various agents such as the nucleic acid polymerase or NAPs. There's a lot of focus on these drugs at present because they seem to be really quite beneficial in terms of achieving surface antigen loss. Now, the studies are quite varied. Many patients are treated with NUC, so virally suppressed with NUC. Then you get the addition of pegylated interferon and the NAP. And then we've seen various data and various readouts of these, specifically in the REP 2139 and the REP 2165, which have been around for the longest. And we've seen quite significant data from these. And essentially what we're seeing in these, in the use of the NAPs, is that we're seeing really quite marked reduction in the various constituents in surface antigen, but in the next generation measurements of surface antigen, so next here, so more detailed or more, how would I put it, precise measurements of surface antigen, telling us that even in these more critical levels of surface antigen reduction, the NAPs are able to deliver functional cure. And we're even seeing that in some of these functional cure patients, we're getting seroconversion with the emergence of surface antibody. Pregenomic RNA and the correlated antigen that you saw in the capsids are also below level of quantitation at the end of treatment also. So these NAPs seem to be having a much more dramatic effect, are clearly delivering functional cure based on these data as I show you here. So this is something definitely we need to consider as a strategy as we move forward to achieve functional cure. Finally, I'm going to talk to you about immunologic targets, because up until now we've focused on the viral targets. And here I'm just going to mention a few of them. And they are stimulation of innate immunity, so TLR agonists, blockade of immunosuppressive pathways with anti-PD-1, anti-PD-L1, and then finally production of virus-neutralizing antibodies by B cells, therapeutic vaccine. I won't discuss all of these today, but I will just focus on the TLR agonist and the anti-PD-1. This is a slide that I've shown you before at some of the previous meetings in Cairo, but I want to show this again to you because this is a really simple slide which highlights to us that patients with chronic hepatitis B have a dysfunctional immune response. So no matter what you do in terms of virological targets, you're still required to do something to restore this dysfunction or this immune dysfunction that you get in patients with chronic hepatitis B as they get older. So this is where the immunological targets come into their fore. Are they able to restore some of this immune dysfunction? So this is one such target, it's the TLR8. And in previous meetings in Cairo, I've discussed the TLR7. This is Gilead's TLR8. And in a nutshell, I'm not going to spend too long on this, but the TLR8 was, how will I put it, but welcomed as a next generation TLR, which would provide more in terms of its ability to achieve cure rates. But unfortunately, it really didn't deliver there. And what it in fact did is that it provides little in the way of surface antigen loss in both cohorts that it's looked at. So we've got both e antigen positive, e antigen negative, surface antigen loss, but of the order of about 5%, which clearly is not satisfactory in this case. If we move on to look beyond this, and this is the anti-PD-1, anti-PD-L1 blockade, what we see here is, this is data again that you'll have seen from Ed again a couple of years ago now, and this is, what is the role of anti-PD-1? Is anti-PD-1 able to restore immune function that I just showed you from some of our basic science work? Well, again, if you look at these data, you will see one patient who achieved surface antigen loss. Now, this is just a proof of concept study. It's very limited in terms of number. It's limited in terms of what we can draw in terms of conclusions. But in terms of a proof of concept, when you use an anti-PD-1 in combination with therapeutic vaccination for virally suppressed patients, you are able to achieve surface antigen loss in one patient. And strikingly, in this one patient, the patient who achieved surface antigen loss was the patient who had the greatest ALT flare, suggesting to us that we restore the immune response by reversing that PD-1 dysfunction, providing an immune trigger, and in doing so, being able to restore the natural host immune response and achieve functional cure. Finally, and this is my last slide, this is something I've showed you in previous years also in Cairo at the meeting, and this really highlights the various targets, both immunological and virological, with immunological down here at the bottom, some of which we just discussed, checkpoint inhibitors, anti-PD-1, anti-PD-L1, therapeutic vaccination, immune stimulation with the TLR agonists, and of course T-cell therapies and immune modulation, which we expect downstream. But combined with this, I think now there's a recognition in the field that we will probably need to use these immunological therapies in combination with some of these virological targets that I just discussed. So again, to remind you, entry inhibitors, of course, silencing RNA, so the siRNAs, the antisense oligonucleotide, blocking antigen secretion, which we talked about, and the CAMs or the capsid assembly modifiers that we talked about. It's most likely that we will need a combination of both these immunological and virological targets in order to restore immune function and to deliver functional cure. So finally, in conclusion, what I've covered today is that NUCs can achieve HBV DNA suppression, be that entecavir, tenofovir, and now TAF, which you're using in Egypt, are highly effective, very well tolerated, and work really, really well. So NUCs are really a huge bow in our armor, I would say. But unfortunately, their effect on surface antigen is minimal because their effect on both cccDNA and integrated DNA is of questionable significance at this stage. Then I reviewed many of the various NUC discontinuation studies and showed you that they can reduce surface antigen. They have a capability in doing this, but stopping NUCs is limited in its ability of achieving surface antigen loss, and it doesn't seem to have a place in the treatment of Asian patients, which of course are the most numerous patients with chronic hepatitis B globally. There may be a role for certain Caucasian patients with certain disease profiles. What about the upcoming novel agents with different modes of action, have established antiviral efficacy, and we've also established that the safety profiles are good in some of these drugs, so we can definitely move these forward into later phase trials, which is a very good sign. The effects of more suppression of HBV DNA, the novel suppression of pregenomic RNA, a surface antigen, means that they will have a role in functional cure, but are likely to need combination with other agents. Then the question, of course, becomes, how do we combine these drugs, and what will the combinations be? Will it be combining different antiviral agents, be that 2 or 3 agents and dual and triple therapies? Will it be combination with immunomodulators, which is, I think, most likely where it will be? And then when you do that, the next question is, how many times and for how long do you need to use these immunomodulators, siRNAs, antisense oligonucleotides, anti-PD-1s, and what the duration of these drugs will be? So I would conclude by saying that chronic hepatitis B treatment is on the verge of major change. I think it's a very exciting area, and we have multiple trials at my own institution that I'm leading on at the moment. And you're going to see more data emerging from these trials trying to achieve functional cure in the coming years. It's been a real pleasure to give this talk again. As I said at the outset, I'm just sorry that I'm not in Cairo to join all of you, but this is the next best, and it's been a real pleasure. Thank you for your attention.
Thank you, Professor Patrick, for your illustrative and well-structured lecture, and for all these novel information about the drugs toward the cure of hepatitis B. And we hope to see you in Egypt soon, inshallah. And now I would like to present the next speaker, our teacher, our mentor, and our professor, Dr. Ahmed Shawqi, Professor of Internal Medicine, Gastroenterology and Hepatology at Shams University, and his talk will be about hepatitis B virus and immunosuppression. Please.
Thank you very much, my colleague, Dr. Ashreen. Thank you, Dr. Siraj, my professor. He is my professor since more than 20 years or 30 years or so. I am happy to be with you today. I want to comment, a very short comment on the previous lecture. Merclodex is now present in Europe under the name of Hepaclodex. Hepaclodex is given subcutaneously 2 milligrams per day, single or combined with nucleotide or nucleoside for hepatitis B. And there is a difference between what's called functional cure and true cure or sterilization. Functional cure, surface antigen is low, DNA is low, and no antibody. Sterilization or true cure is disappearance of CCC DNA in the hepatocyte. This is the target of new treatment, not functional cure. Okay, I go to my lecture, hepatitis B virus and immunity. My colleague, Dr. Shireen, told me to talk about hepatitis B virus and immune suppression, but I have to speak about autoimmunity and hepatitis B virus. As all of us know, there is some extrahepatic manifestation with hepatitis B virus. All these extrahepatic manifestations are immunologically produced. To cause autoimmune disorder, we must have autoreactive T cells. Autoreactive T cells are present normally, but our body gets rid of it before it causes damage to our body. This can be done through sequestration in the thymus or through analgesic depression in the periphery or silencing by regulator T cells. On the opposite side, how autoimmunity produced by an organism, whether virus or bacteria. This can happen through various mechanisms, about maybe 8 or 7 mechanisms. Epitopic spreading. There is some epitopes common between the organism and the body. Molecular mimicity, bystander effect, superantigen effect, formation of immune complex, expression of major histocompatibility antigen on non-immune cells, direct inflammation and damage, necrotic or apoptotic effect. Epitopic spreading, this means that the virus has some epitopes similar to what present in our body. And our body form antibody to attack these epitopes. These epitopes are present also in our body. So autoimmunity happen. The next mechanism is complete biomicity. This is for rheumatic fever, for example. Sometimes the antigen in the organism, whether virus or bacteria or anything, has the same antigenic picture on its surface like our body. So when we attack this organism, we attack our body. Bystander effect, this means that the virus carry something new, but this something new is similar to something present in our body. And so this effect happen. Super antigen. The virus or the bacteria or any organism is so strong antigen. It induces a lot of antibodies. Very big group of antibodies. Some of them are autoantibodies by chance. And so autoimmunity happen. Formation of immune complexity is very well known for us. Antibody, here I want to highlight something we may remember. Hepatitis C virus, we diagnose it with antibody. We do hepatitis C virus antibody, so we say this patient has or may have C virus. So the patient with C virus has antibody, but they are not protective. They may be much better than, worse than that. It is affecting our body in a bad manner, forming immune complex. This would happen with COVID nowadays. But I want to say that formation of immune complex may happen between the virus or bacteria or our antibody and deposited in tissues and cause destruction for our body. Again, the major histocompatibility antigen are present on immune cells only. When infection happen, whatever, by bacteria or virus, this antigen presented on non-immune cells. So the attack of them cause autoimmunity. Direct inflammation and damage. All of us know how the liver gets rid of the virus. The infected hepatocytes are killed, destroyed. The cell and the virus, both of them are destroyed. And the liver has a very high regenerative power. But what happens when the cells are destroyed, they release antigen present inside the cell, are not exposed to the immune cells. So they get activity and cause autoimmunity. Again, necrosis or apoptosis, the same mechanism. Hepatitis B and autoimmune disorders. What are the autoimmune disorders associated with hepatitis B? First of all, prodroma of looks like serum sickness happen with hepatitis B virus. Membranous glomerulonephritis, membranoproliferative glomerulonephritis, cutaneous vasculitis, mixed cryoglobulinemia, polyarthritis nodosa, or B virus with other autoimmune disorder, with lupus, with rheumatoid, and so on. This is the first part of my lecture in very short manner. Again, we are going now to what if a patient with B virus are in need for some drugs which depress immunity. How can we manage? As we see, the previous lecture discussed all these points. I'll skip this. I skip this also. The life, how the virus enter. لا أنا معلش نطيت. برضو I skip this. This is in the previous lecture are discussed. What is the net result of treating hepatitis B virus patient? First, the surface antigen is present, DNA is present. The patient is not responding to treatment. Second, the surface antigen is present, but the DNA get lower. Below, I want to stress on a very important point. All of us know the ASLD and so on and so on. They say the hepatitis B DNA, if above 20,000 international units, give treatment if it is E antigen positive. and over 2,000 give treatment if above, if E antigen negative. The golden number of DNA at which the patient have the same risk of hepatocellular carcinoma and fibrosis is 300 international units. Is 300 international units, which means 60 copies. Above this level, the patient has a higher probability of developing hepatocellular carcinoma and cirrhosis. The second scenario is S antigen is present and DNA get very low. We give this the name of functional cure. The patient has very low DNA, surface antigen is still present, but the AST and the LAT are normal, no inflammatory process. Again, surface antigen disappear and surface antibody appear. We consider this as a functional cure, is a very good result, but we forget that the triple C DNA is still present in the liver cell. For our knowledge today, we say that if surface antigens appear, surface antibody appear, and DNA is very low, the patient is cured. No, he has triple CC in his blood. How to detect this triple CC? The only sure way is pre-genomic RNA. Pre-genomic RNA level, or the C-related antigen. The only way to detect away from pathology and staining and so on, which is not easily done. In all these patients, we still have triple CC in their liver. All of them are at danger of reactivation if giving any immunosuppression. Even if the patient has no surface antigen and surface antibody positive and anti-C antibody to differentiate from immunized person. Immunized person has surface antibody, no surface antigen, no DNA, but no surface and no hepatitis B core antibody. If the patient has surface antigen negative, surface antibody positive, DNA very low or not detected, and hepatitis B core antibody present, IgG of course, this patient is cured from our point of view. But he is not truly cured, he is not sterilized. He has triple C in his hepatocyte. So, this patient is liable to reactivation, as I said. Nowadays, we have a lot of drugs which depress the immunity of the body. On the top of the list of corticosteroid. If a patient needs corticosteroid for a long time, like autoimmune disorder, rheumatoid, lupus, anything like that, you must check first the presence of B virus. And you may give treatment before starting this corticosteroid. Of course, we have the biologic. Nowadays, there is an era of biologic treatment in various branches of medicine, like rheumatology, like hematology, even in chest diseases. Nowadays, the biologic treatment in ulcerative colitis and Crohn's disease and so on. We must check for P virus before starting this. This table, الانتي اللي هو الريتوكسيماب very high to reactivate in surface antigen positive person and moderate in negative person. A corticosteroid, as you see, as I said. So if we have to give this for the patient, we must check first if he is B virus surface antigen or surface antigen negative. If surface antigen positive, we must check the DNA. If the DNA is very low or not present, we may give treatment and follow every 3 months. If DNA get rise, we must give treatment for B virus. If he is surface antigen positive and there is DNA, we must give treatment of B virus before starting the biologic treatment. If he is surface antigen negative, we must do core antibody. If core antibody are positive, we must follow up, we must give treatment before giving the biologic or immunosuppressive. If the core antibody are negative and we are sure that he has B virus, we must start treatment. If he is, of course, if he is vaccinated and have no B virus before, we can give treatment without treatment of B virus. Thank you very much. Any question? I am ready.
Thank you, Dr. Ahmed, for your elegant presentation, and we can postpone the questions to the end of the session. And now it's my pleasure to present my dear colleague and friend and co-worker, Dr. Iman Fauzi, and her presentation about the hepatitis B virus in the context of liver transplantation. She's one of the eminent doctors who is working in the field of liver transplantation.
Thanks very much, Dr. Shireen, for your nice introduction. Thanks for Dr. Sarab for his kind invitation. I'm very pleased to be with you in this very important meeting and this very important topic about HBV in the liver in the context of liver transplantation. My agenda for today is the pre-transplant management of HBV recipients, post-transplant management, and the management of positive hepatitis B core antibody donors. As we all know that the initial results of liver transplantation for chronic hepatitis B in the 1980s were disappointing, as graft reinfection rates were approaching 200%. And in many patients, the reinfection was associated with severe and rapidly progressive liver disease, resulting in 2-year graft and patient survival of 50% only, compared to 80% in those transplanted for other indications of chronic liver disease. Since then, the introduction of effective measures to prevent and treat the reinfection using the strategies involving the hepatitis B immunoglobulin, the passive immunization, and the subsequent development of various nucleoside and nucleotide analogues have significantly improved the outcome of liver transplantation and the overall survival of patients transplanted for HBV-related cirrhosis exceed 85% at 1 year and 75% at 5 years. For the pre-transplant management of hepatitis B virus recipient, sure that all patients on the transplant waiting list with HBV-related disease should be treated with the nucleoside analogues. This is recommendation grade 1 by the most guidelines like the European and the American Association of Study of Liver Diseases. The need of antiviral treatment for these patients have 2 objectives. The first is to improve the liver function. It can result in deactivation of or delisting of the patients on the waiting list, and to decrease the risk of HBV recurrence after transplantation, since the viral replication level at the time of transplant correlate with the risk of HBV recurrence post-transplant. Patients with positive HBV DNA at the time of transplant seems to influence the rate of mortality due to HBV recurrence and HCC. Until recent years, we didn't transplant patients with HBV DNA positive at all. So the choice and timing of therapy, since the interferon is contraindicated in decompensated cirrhosis and also it is ineffective in certain genotypes like those present in Egypt, the only choice is to start with the nucleoside analogues. Damobudine and adifovir was the first used in these patients. However, the newer drugs, the tenofovir and entecavir, are currently the first-line therapy for these patients with greater potency and higher barriers to resistance. Entecavir is preferred in patients who are naive and who had prior treatment to adifovir, while the tenofovir is preferred for patients who had prior treatment with lamivudine or telbivudine. antiviral therapy for sure should be continued indefinitely post-transplant. This is one of the data from the earliest data of the hepatitis B surface antigen seroclearance following liver transplantation in patients receiving entecavir. And as we can see on the top to the left, the cumulative rate of HBV surface antigen seroclearance reaching 91% on treatment. However, if we look on the last figure on the right side, the cumulative rate of HB surface antigen relapse after initial seroclearance is quite high, reaching 13.7%. In special situations like patients with fulminant or severe hepatitis, they may benefit also from nucleoside treatment prior to transplant. Also in patients with HBV, HDV co-infection, treatment of hepatitis B is indicated. And the presence of HDV replication is not a contraindication for transplantation, since HBV prophylaxis after transplant is given and prevent the symptomatic HDV reinfection of the graft. For the post-transplant management, the prevention of hepatitis B virus reinfection was including both the use of antiviral therapy pre-transplant and continued both transplant, as we said, and together with or without the passive immunization with hepatitis B immunoglobulin post-transplant. And these strategies had led to reduction in HBV reinfection rates to less than 10%. Here we categorize. Nowadays, all papers are categorizing patients according to the risk of reinfection, and patients who are eligible for liver transplantation are divided into high-risk patients and low-risk patients. High-risk patients, including patients with e-antigen positive, e-antigen negative, but with high serum DNA levels, patients with antiviral drug resistance prior to transplant, and HCC patients. For the low-risk patients, HBV fulminant infection, co-infection with HDV, low or even undetectable HBV DNA levels, whether spontaneously or under treatment. High doses of hepatitis B immunoglobulins was used as a standard prophylaxis for HBV reinfection in most transplant centers prior to the availability of effective antiviral therapy. But with the introduction of effective antiviral therapy, the hepatitis B immunoglobulin can often discontinued after 1 year in patients with high risk, or even not necessary at all at patients who are at low risk, like patients entering the operation with HBV DNA negative. Patients with high risk of HBV reinfection are given the prophylaxis with the combination of hepatitis B immunoglobulin together with the nucleoside or nucleotide analog for 6 to 12 months and indefinite antiviral therapy thereafter. This figure can show the effect of hepatitis B immunoglobulin after liver transplantation. And here we can see that patients with associated cirrhosis were randomized to long-term, short-term immunoglobulin or no immunoglobulin prophylaxis after liver transplantation. It is clear that patients treated with long-term immunoglobulins had both lower incidence of surface antigen recurrence together with higher rates of survival. Again, these data are old data from 1993, before the development of effective antiviral therapy. The dose regimen, hepatitis B immunoglobulin, is given at high dose intravenous 10,000 international unit bolus dose during the anhepatic phase, followed by daily dosing during the first week. Different strategies and different protocols aiming for hepatitis B surface antibody titer of more than 300 to 500 during the first year post-transplant to patients with high risk of reinfection. However, the cost of immunoglobulins is very high and the availability today are very limited. It is estimated that high dose intravenous immunoglobulin can charge for $80,000 to $200,000 in the first year. In Egypt, post-transplant period just for the anhepatic phase and during the first week, it can add on about 100,000 Egyptian pounds, and it is not available in the markets nowadays. So to reduce the cost, attempts have been made to increase the interval between intravenous immunoglobulin dosing or to substitute maintenance dose with alternative intramuscular administration or to discontinue the hepatitis B immunoglobulin in the most vulnerable period. Another attractive way is the active immunization. Active immunization using the standard hepatitis B vaccine have been studied to reduce the need for long-term immunoglobulin prophylaxis. And most studies have focused on low-risk patients who are more than 1 to 2 years post-transplant, the long-term recipients. However, these studies found that the response rate were variable under the immunosuppression, varying from 8 to 80%, and that anti-hepatitis B surface antibody titers achieved in responders were low, despite the use of higher doses and multiple courses of vaccine. By the way, in these patients, we need the hepatitis B surface antibody titer above 100, not like the general population above 10. So another important and hot topic in transplantation is management of the potential donors with isolated hepatitis B core positives. Eliminating the livers from isolated hepatitis B core positive individuals could result in a significant reduction in the potential donor pool, particularly in countries where HBV infection is endemic. So reserving livers that are anti-core positive for recipients with hepatitis B is one of the potential approaches, since such patients will already receive HBV antiviral prophylaxis for life. This slide could show the risk of reinfection, the lowest risk reaching 0% in HBV surface antigen and HB core positive recipients. The intermediate risk in anti-HB surface antigen positive and anti-HB core positive also reaching about 12%. The highest risk, and I think this is not acceptable, the anti-HB surface antigen and anti-HB core negative patients without prophylaxis, the risk of reinfection reaching 76%. So hepatitis B surface antigen negative patients receiving livers from donors with evidence of past HBV infection, anti-HBV core positive, are at risk of recurrence and should receive antiviral prophylaxis for life. For the recognition of de novo hepatitis, this is challenging since the onset of infection is not predictable and may be delayed as long as 5 years post-transplant. For recipients who are anti-core positive livers, receiving anti-core positive livers, most of the studies describe initial monitoring every 1 to 3 months for the first year, then every 3 to 6 months after the first year. So my conclusion for today, all transplant candidates should be tested for HBV surface antigen, anti-surface antibodies, anti-core antibodies, and optimize the risk assessment, and this could guideline the management before transplantation. Of course, HBV vaccination is recommended for all non-immune transplant candidates, and for chronic hepatitis B patients with undetectable DNA at time of transplantation, they may not require HB immunoglobulin post-transplant, while short course of immunoglobulins is warranted in patients with detectable DNA at time of transplantation. The choice of treatment for recurrent hepatitis B following liver transplantation depend upon prior prophylactic therapy and the presence of drug-resistant mutants. Organs from hepatitis B core positive donors should be considered for adult transplant candidates after an individualized assessment and risk and benefit appropriate patient consent. we usually consent to the patients in this situation that you are receiving an organ from hepatitis B core positive donor, and there is some risk of reactivation, and you must take the antiviral therapy, the nucleotide therapy for life. Indefinite antiviral prophylaxis is recommended for liver transplant recipients for HB core positive donors, and HBV DNA with or without a surface antigen should be monitored every 3 months for the first year, then every 3 to 6 months indefinitely. Thank you all, and I would like to thank my team in Ain Shams University. Thank you for attention.
And now we have about 15 minutes for discussion if the chairpersons would like to comment.
Dr. Ahmed Shawi, you said that patients who are transaminases normal level and they are surface antigen negative and positive for all antibodies, which means surface antibody, and core antibody are positive. This could be simple functionally cured, or actually they are sterilized. To differentiate, you have to do the markers or the biopsy for the CCC. So this is routine before giving therapy, immunotherapy for a disease patient who have these markers, or we should follow up only while giving him the steroids.
Thank you, my colleague, Dr. Yahya. In what is practically done today, we consider this patient is cured. All of our colleagues consider it cured. What I advise is that usually you don't give antiviral treatment before giving biologic. But if the HBC antigen, C antibody positive, if hepatitis B C antibody positive, he must give antiviral treatment, because this means that the patient has at one day has infection with P virus. On the opposite side, they can start treatment and follow up the patient, especially in the first 3 months. They can do surface antigen, may appear again. The surface antigen may appear again. The first thing to detect is a reappearance of surface antigen or increased level of DNA if it is not positive before treatment. If they appear, he must give antiviral treatment.
Now, I want to say that if I know that this patient was B,
I must
and
give.
he took treatment,
I must
and
give.
he develops 3 antibodies: the surface antibodies, the core, and the E antibody.
My
the
opinion,
antibodies, you cannot differentiate whether this is
Yes.
functional cure
Yes.
or a sterilized patient, and you
Yes.
don't do the markers for this.
Yes.
So we told him that you are cured. If this patient gets rheumatoid arthritis and he wants to take Humira, for example, should you do these investigations or give him antiviral therapy?
These investigations are not available in Egypt. Are not available. So he cannot do it. So
That's why you have to consider them.
my opinion,
until proved otherwise.
in my opinion, he must give antiviral treatment. In my
Even
opinion.
if you know that this patient was positive and he took treatment as he's cured, you will repeat the virus.
There is no cure with nucleotide and nucleoside. There is no sterilization. It is not proved at all.
You cannot say, since you
I cannot say, yes,
detect
I
the
know.
triple C, you cannot say.
Yes,
So
I cannot say.
presumably he is cured and you stop treatment.
I have choice between 2 things. Either to be conservative and give antiviral treatment, or to follow up without treatment.
Yeah, because if I gave him treatment, when I should stop this treatment and start the Humira?
We give together and simultaneously. We start 2 weeks before it
So
starts.
you will give it for long, for life.
Yes, for a long time. Or the opposite, the other choice is not to give antiviral treatment and follow the patient, especially in the first 3 months.
This is more practical.
Okay, more
I mean.
practical. Okay,
Yeah.
okay, I agree.
بالبي سي ار unless one of three situations. حضرتك بتتكلم على الكور انتي بودي اللي هو السيرفيس انتيجين نيجاتيف، بي سي ار نيجاتيف، السيرفيس انتي بودي بوزيتيف اور نيجاتيف، مش هتفرق. انما when to give treatment and when to follow preemptive اللي هو الفولو اب اذا حصل ري اكتيفيشن بالبي سي ار تدي. احنا بنتابع بالبي سي ار الا في 3 حالات. لو في ترانسبلانتيشن، السيتنجز اوف ترانسبلانتيشن، اي حاله فيها ريتوكسيماب هيتاخد او البي سيلز انتي بي سيلز، لان دي بتضرب الهيباتيتس بي اميونيتي في مقتل. الحاله الثالثه السيروزس، مش انكريزد ريسك اوف ري اكتيفيشن، انكريزد اوتكم. اي عيان ان اكتيف سيروزس وهياخد بيولوجيكس عاليه، حضرتك هنديله مش علشان الانكريزد ريسك، لا، انكريزد ريسك اوف اوتكم. لو حصل له هيروح فين؟ دول ال3 حالات حضرتك.
السيروزس بنعمله حتى من غير ما
لا
ديتكت الاتش
ده
بي
حبيبي
ما هو السيروتيك.
استاذي لو هو نيجاتيف سيرفيس انتيجين ونيجاتيف بي سي ار وهديله كيموثيرابي، هديله هو في الحالات العاديه كتريتمنت.
لا هو لو سيروتيك لازم هكمل التريتمنت ايفن لو مش هديله
لو
كيمو.
ما كانش بياخد ان اكتيف سيروزس من الاول يا باشا. لو هو من الاول ان اكتيف سيروزس يعني بي سي ار نيجاتيف، ما هو السيروزس عايز بوزيتيف بي سي ار. هو مش
لا انا بتكلم على بيشنت اوريدي كان بياخد. لو هو سيروتيك مش هوقف.
ايوه يا فندم، ايوه ماشي. هم 3 حالات بس اللي ممكن حد فيهم لا.
I have a small comment for Professor Kennedy regarding the new treatment modalities. I just wonder about those new measures targeting the inhibition of entry of the virus in the hepatocytes. It was suggested in the lecture to belong as a therapeutic measure. Why didn't you suggest them as a prophylactic measure, particularly in the post-exposure situations? Not therapeutic, but prophylactic.
Well, it's a good question, but these drugs are extremely expensive. And just to correct what the first speaker mentioned after my talk, these drugs are not designed in terms of clinical trials to deliver sterilizing cure. I don't know where he gets that from. I'm involved in the design of these studies and the delivery of these clinical trials. We think that sterilizing cure is out of reach of all the current drugs, which, by the way, are being investigated. To achieve functional cure is what is within our reach and is possible. And this is why all these clinical trials are designed to achieve functional cure, not sterilizing cure. And, you know, you could use Mercadex, yes, as a prophylactic, but this is an extremely expensive drug and has to be given continuously and at present by injection. So these are not drugs that would use as prophylaxis, whereas the discussion around the use of nukes for prophylaxis and reactivation makes a lot of sense because they're very cheap and they're very safe, and we've used them for absolutely years. So you have to measure up when you're using a drug, its utility, its safety, and what actually it's doing, and is it economically viable? And these are the things that you have to use. And that same, I just picked up on, you know, the discussion around reactivation. You give nukes as prophylaxis against reactivation after you risk stratify the patient. So for example, the last person mentioned rituximab. Rituximab is the one drug which is badged, as with B-cell depleting agents, as a high risk of inducing reactivation. And anybody who gets rituximab who's core antibody positive should have a nuke before they start that. But you know, the patients who are on Humira, many of them who are core antibody positive, will not need a nuke. And you need to risk stratify that patient to think whether you think that patient's at a higher risk of reactivation or not. One of the things which might help you is the level of hepatitis B surface antibody. So that may determine, there's some data emerging that may determine some of the risks around reactivation. So I think people need to approach these patients on an individual basis and make a decision in terms of risk stratification of what you would use.
Thank you, Professor Kennedy.
Is there any further questions? I have just one comment to Professor Patrick. I need you to highlight the immunological mechanism by which around 90% of adults who acquire hepatitis B infection can cure the virus, while 5 to 10% only can have chronic infection. And by knowing this mechanism of the immune system, we can reach the cure of the hepatitis B. Thank you.
You're absolutely right. And that's a critical observation because, you know, what we know is that the host immune response has the capability of clearing the virus. That's clear. 95% of adults will clear surface antigen and have a functional cure. The reverse, of course, is that a child under the age of 4 with a weak or immature immune response is incapable of mounting that robust immune response. And as a consequence of that, the 95% of children under the age of 4 who are exposed to hepatitis B will develop chronic hepatitis B. So we know that the host has the capability of clearing the virus. We know that children perinatally or vertically exposed to virus will go on to develop chronic hepatitis B. And we know that adults, when exposed, will clear the virus. So what we do know is there is a medium where we can get to where the host immune response has the capability. Unfortunately, children don't have that, so we're not able to do anything with that. So what we can do, if a child is exposed to hepatitis B, develops chronic hepatitis B, this makes a very strong argument that we should be intervening earlier in the course of chronic hepatitis B before somebody is in their 50s or 60s, where the chances of restoring that immune response are probably gone. But yeah, I mean, it's an observation. We know that observation, and we know that in a healthy adult, they will clear the virus. That just gives us I would say, the guidance that by modifying, by manipulating, by modulating the host immune response, we should be able to clear the virus because we know that the host has the capability of doing that.
Thank you, Professor Patrick, and thank you, chairpersons, for your valuable contribution today, and thank you for the speakers for their presentations.